Well, I'm really glad we started this panel with some wonderful success stories because we're all very good at examining all the reasons why we still have this translation barrier of actually applying evidence. And when my slides come up, I'm going to talk about of one of those barriers that I think many in this room are aware of, but really talking about the role of academic incentives. When we think about knowledge producers and what they're doing, are they actually rewarded for actually taking that knowledge that they've helped to produce and getting it used? So taking a page from the world of healthcare system improvement, there's a quote that's Paul Batalden, but it's been used many times since, that every system is perfectly designed to achieve the results it gets. And whether it's population health research or anything else, researchers are designed and trained to have peer-reviewed publications, research grants, conference presentations, and teaching. Those are the incentives that researchers generally live in. And while we're using, in this country, we're sort of enamored with behavioral economics as often the solution to get patients to do things differently, to get providers to do things differently. We haven't really talked about behavioral economics and getting researchers to do things differently. So I think we should apply some of our own science to ourselves. And then this quote, I heard it actually at an RWJ meeting, and I can't remember the name of the individual who said it, but it really hit home. You can read it for yourself, that academic institutions are pretty entrenched and pretty hard to change. And so as we think about our desire to have population health research developed that's relevant and that will be used, we're up against some pretty significant odds. But there are some hopeful signs out there. This paper was written by a Canadian. It was a very good article about talking about whether a new paradigm is emerging. And the three dimensions of this new paradigm was the emphasis on interdisciplinary, which we've talked a lot about in population health research and how critical it is. And that a trend towards increasing sort of engagement of non-academic partners in trying to identify the problems. And then an increasing focus on knowledge transfer. Now, I said at the beginning, this is a Canadian article. The Canadians, in my personal opinion, are pretty far ahead of us in knowledge transfer. So I'd say, when I grew up in Europe, they'd say that when America catches a cold, Europe gets pneumonia. Here, I'd like, when Canada, does something right, it might take us a long time to catch up. So the reverse. And this is not a new issue for Academy Health. As David mentioned, I'm with Academy Health, which is the Professional Society for Health Services Research. We have an interest group on public and population health. Kate Papa, who's our director of that interest group. So population health, as David knows, as a former keynote speaker at our meetings, has been a focus of a part of our association for a while. Already now, almost 6 years ago, this paper was co-authored by a number of colleagues, including Polly Pittman. And it identified a number of challenges, did key informant interviews. And I'd like to say that the world is a lot better now than it was 5 years ago. But I think many of you who are in the academic or in the academy sector of our country still feel many of the pressures and context that this report alluded to. However, more recently, Peter Szilagyi wrote in Academic Medicine that the pressures on the academy are shifting, that increasingly, and there's a recognition of the need to focus on population health. Not just, this is primarily from the aspect of academic medical centers, so not all, obviously population health researchers are in many other institutions beyond medicine, public health, and in arts and sciences and many other parts of the academic enterprise, but at least in this sector, the focus on population health is emerging in part, Peter talks about, because so many of these institutions are in low-income communities, are recognizing the growing inequalities and the sort of the depth and pervasiveness of the challenges in their own neighborhoods. There's increasing demands to serve the public good. Some of you may know about the pressure on 501c3 institutions to show that they're contributing to community benefit benefit. And so rather than being able to simply discount and claim that all the uncompensated care I provided is my community benefit because I lost money serving those people, and I'm saying that on purpose, there's now much more accountability for really contributing to community health and population health. A more recent initiative, the Clinical Translational Science Awards, how many of you have participated in any of those? Okay, a couple of you. So there's been an emphasis on community engagement, which has been watered down in the more recent iterations of the associations, but it's really sort of valorized within the science community funded by the NIH that there is a role for community engagement and working outside the walls of the academy. And then more recently, whether academic health centers need to now become accountable care organizations and actually be measured on whether or not, and rewarded and paid on whether they contribute to population health. So all of that is contributing, I think, to, and I'm an optimist. We heard a lot about different types of frames yesterday and today. And so I believe that there is a shift and an opportunity for this country to do a much better job on knowledge translation. And one of the dimensions of this is the growing interest in research impact assessment. So the question being asked, what difference did your research make? And again, this is an area where actually we're behind again in our use of this, and but we're seeing growing interest in it in this country by both funders and others. So again, I will not read this, but it's very much about understanding the so what of funding research. And so as you think about how do you evaluate research impact, there are clearly the traditional tools that we've all used or seen used, bibliometrics. How often do you get cited? How often now are you downloaded? All kinds of different bibliometrics, including more recent altmetrics, which are, I think, expanding our view of some of the more traditional ways of measuring impact. There's more emphasis on case studies, some cost-benefit analyses, and then peer review not of individual scientific articles, but peer review of a body of evidence, or convening scientific panels to come in and assess a department and say, how good is the science and what impact is the science in this department having? And I've participated in departments of pediatrics and others in those sort of more broad peer assessments. How many of you have ever heard of the payback framework? Okay, so one. So this was developed in the UK. I was actually part of a meeting in 1996 when this was pretty new on the scene, where the NHS had said, how do we know that the NHS's investment in research, primarily health services research, was having an impact and a return on investment or payback to the NHS? And so Martin Buxton and Stephen Haney developed this framework that it's multidimensional, which also read complicated, so it's kind of hard to implement in the assessment of research impacts, but it's a very comprehensive framework. And you can see that it looks at all kinds of dimensions, both the contributions to knowledge, to future research and research use, benefits to policy, health and health sector benefits, and then broader economic benefits. So in several other countries, funders are taking note of this impact assessment trend. And in fact, there's a new international school of research impact assessment. They had their, I think it was their second meeting in Banff about a year and a half ago, and their next meeting is in Qatar, if anybody wants to go to Qatar, but I can give you the connection there. And in fact, the AAMC has commissioned a report on research impact assessment. The AAMC is the the Association of American Medical Colleges. Important distinction, it's only for the US-based medical colleges. Always mix up the two A's. But in England, the UK, it's really where there's been the most use of this with what is called the Research Excellence Framework, which is a new peer assessment system, again, back to the peers, for evaluating the quality of research in higher education institutions. A very much smaller and less aggressive example in the US is the National Science Foundation's use of the BIC, or Broader Impacts Criterion. How many of you are familiar with the BIC? Broader impacts criterion. Okay, so that's, I'm going to talk a little bit about each one quickly. Minute left. Okay, the Research Excellence Framework defines impact, as you can see, as any effect on change or benefit to the economy, et cetera, but clearly beyond academia. And the outcome of this assessment, importantly, is used for funding allocation, accountability, and benchmarking. And this was a major shift in 2014 for the Research Excellence Framework. And when I was in the UK the last 2 years for their counterpart meeting, it's really affecting how the academics think about this, and created a whole economic engine of funding impact case studies to try to find out what difference was our institution making in the broader society, not just in health and medicine, but all aspects, media, arts and sciences, et cetera. And you can see in the last set of bullets here that the impact of the research beyond academia was actually 20% of the assessment. And so it directly affected the score you got, which directly affected how much money you got. So a very direct link between making a difference and how much research dollars you got. And here is the top half of a very long graph. I didn't put the whole graph here so you could actually see something. But this is based on a study that Jonathan Grant and his colleagues did at HEFC, I won't get into the acronyms, but looking at the impact case studies, of which there were almost 7,000 of them, 7,000 collected from the various institutions. Any one institution of higher education did between 2 and 250 case studies, with variation based on the size of the institution. And you can see that the top number of case studies were in public health and health services. But if you go down, you can see it's really across all aspects of higher education: historical studies, law, political science, statistics, sociology. So many of the disciplines in population health were included and reflected here. And again, I can send anybody a copy or of this report. So clearly, very, very interesting work going on that we might be able to learn from. Back to the US, the National Science Foundation BIC program, which is, again, the broader impacts criterion. This is taken from a report that was done going through 87 applications. So it's a subset of 87 NSF applications to look at what researchers are describing that they're going to do for this broader impact criterion. And you'll see on the right-hand side what the BIC outcomes are. Now, at the time that this study was conducted, it was through 2011. Since then, they've added a couple more outcomes, including national defense and a broader, more specific economic impacts as well. But to date, in this evaluation, looking at what researchers say they're going to do, they're still staying in their safe zone of, oh, I'm going to present at a research conference, I'm going to publish a peer-reviewed paper. But there were some indications of more innovative ways of trying to get the information out to actual users. So again, I'm going to be hopeful, say it's early days yet, but there is some evidence. So in closing, I've obviously alluded to some learnings and potential models from other countries. Why are we behind? Well, here are just some potential reasons, but I'm sure you can come up with others. Obviously, in assessment, no metric is perfect, and we're the best people to debate the metrics. So especially if those metrics lead to how we're assessed, we're going to argue pretty hard on those. To close, I'm just going to put this up, that basically I think that the demonstrating impact may be particularly challenging for population health research, particularly as we're looking at very much more downstream outcomes, and that time lag might be challenging. But I think there's a tremendous opportunity for all of us to look at research impact assessment, and want to get funders in this country interested in this dimension. Thank you.